Hi everyone, my name is Henny and I'm talking today about adolescents in the Victorian Health Service, and I'm talking specifically about adolescents presenting for sexual health consultations. So the outline of this presentation is to talk a little bit about adolescent development, a little bit about sexual behaviour data we have from Australia, a little bit about young people and sexual health consultations, some cases, and then I'm going to sum up at the end. So just to briefly mention adolescent development. There's a lot to be learned around this, and we run a whole subject at the University of Melbourne on adolescent sexual health when we talk about adolescent development. So I'm literally just going to give you a few headliners just to remind some of you who are probably very familiar with this, but also to introduce you to some of the theories around adolescent development. We know that adolescent development begins at about 11 with early adolescence, and it goes all the way up to about 21 years of age. And we divide it roughly into 3 periods, early, middle and late. And they all have distinct features within their stages. These stages of early, middle and late adolescence aren't particularly tightly contained. They do overlap and the ages are just rough. But at the beginning, we see puberty starting with young people thinking, am I normal? In the middle of their adolescence, they develop these very strong peer identifiers, which you're probably aware of, and move away from their family to become more independent. And later on, they become independent and have thoughts such as, will I make it? What am I going to do? How am I going to contribute to society? Things like that. But they're just the rough stages of adolescent development to be aware of when you're seeing a young person in a consultation. There are tasks which occur during those stages, physical, cognitive and psychosocial tasks, which again, you're probably aware of. And again, these can happen at different stages, but it's important to remember you're not necessarily at the same stage of physical development as you are as cognitive development. And I think this can sometimes be very challenging for professionals and for parents, because, for example, young girls may look very physically mature, but in fact, psychosocially and cognitively may not be very mature. So they're really difficult things sometimes for us to grasp. There are unique challenges in adolescence, and this is really because there are some specific disease patterns, but they can present very unusually. And there are, in addition, unique communication and management challenges for the practitioner. And on top of that, risk-taking behaviours. And just to highlight, risk-taking behaviours are really part of normal adolescent development. And I see it as our job as health professionals, that young people should be kept as safe as possible during those inevitable risk-taking behaviours. So it's about harm minimisation. And again, some of the risky activities around sex, around cars, drugs and alcohol. And the difficulties generally arise because of ignorance, i.e. the young person's had no prior education around this or prior experience of this, impulsiveness and wanting this sort of thrill around sort of fast cars and drink and things like that. Possibly low self-esteem, which is particularly common in young female adolescents in the early and middle stages of development, and cognitive immaturity. All of those things impact and make it really challenging for us to try and deal with these risk-taking behaviours. Something that you hear referred to a lot is that young people, when they're prior to going through puberty and adolescent development, they have very concrete thinking. And when they've passed through all their stages of adolescent development, they develop much more abstract thinking like we have as adults. And when they develop that abstract thinking is very unique to them. So some people may be thinking very abstractly when they're 14, whereas others may not be thinking in an abstract manner until they're 16. There is some evidence to suggest that a lot of young people do start thinking quite abstractly early on in development, sort of around the age of 12 or 13. But as I say, it does vary from an individual to an individual. And just to put it into a sexual health context, concrete thinking is really something like this. So you said I'd get chlamydia if I didn't use a condom, and I didn't get chlamydia. So you were wrong, and I obviously don't need to use a condom. That's a very sort of black and white, dare I say it, example, but that is the sort of way people will think if they think very concretely. But abstractly, people may understand that because they didn't use a condom and they didn't get chlamydia, they were lucky, but they are going to use a condom in the future. So it works very well for chlamydia, for which there's long-term outcomes. That sort of difference between concrete and abstract thinking, and as well with other things like smoking and alcohol, because the consequences may not be immediate. So it is very important to try and establish if young people are thinking in an abstract way and can understand what information you're giving them. And also it can help you predict how they're going to behave in response to education. So if we look at some of the sexual behaviour data in Australia, we've got really good sexual behaviour data in Australia. We've got the secondary school surveys, which were done by Archers at La Trobe, which looked at knowledge, attitudes and reported behaviours, which have been going in a serial basis from 1992 all the way up until 2018. And then we've got the Australian Study of Health and Relationships, which has run twice, 2004 and 2014, which is again done by a sort of conglomerate of universities, including Archers. Which gives us data about sexual behaviour. So because these studies are serial, they're very good at comparing whether behaviour has changed or whether knowledge has changed. And that's what really is really critical, as well as them being carried out very rigorously with large populations. So the secondary school surveys looked at all schools, so secondary schools year 10 and year 12, over more than a decade on a regular basis. And students from Catholic schools, public schools, private schools, a wide range of schools, and a large population of 2,000 secondary school students. It looked at their knowledge, their behaviour, they reported sexual behaviour around penetrative vaginal sex, oral sex, condom usage, unwanted sex and diversity of attraction. And those are the things that I'm going to pick out now to talk about, because those are the issues which people have looked at over the time the studies have been done to see if there's been any change significantly around those variables. So this is looking at significant changes over time, which is from 1992 to 2018. And we can see that general STI knowledge has increased during that time, which is what we would probably expect with an increase in the amount and the quality of sex ed at schools. There's an increased reporting of diversity of sexual attraction amongst young people. And there's an increased number of sources of sexual health information, which is again what we would probably expect because of the wide use of the internet for knowledge around sexual health. If you look at knowledge, and this is looking at where young people get their information, their knowledge about sexual health from, and this is 2002 all the way up to 2018, we can see that the significant places that young people get their knowledge from are their doctor and their GP practice, their female guardian or their mother, their female friend, and school programs. Those are the significant places that young people turn to, and it's been like that since 2002 really. They turn to them for reliable sexual health information. So really important in primary care that we make these services accessible to young people so they can come and ask GPs and practice nurses about sexual health information. Penetrative sex, and again looking at this between 1992 and 2018, we see that men in year 12 in 2018, 31% of them were likely to have had penetrative sex, and in year 12 about 50%, and for females, higher proportion of year 10s have had penetrative sex, and a higher proportion of year 12s have had penetrative sex. But ballpark figures, sort of 30% in year 10, 50% in year 12. No significant change between 1992 and 2018 for that. For oral sex, we see that about 50% of young people have engaged in giving oral sex and receiving oral sex. This was in 2018. So at least half of the class if you're teaching a class. If we look at condom usage, we know that condom usage is high, and it is usually higher very early on, and then it decreases with age. And this is probably to do with the fact that young girls may use an alternative method of contraception and may not think about using the pill, for example, and a condom. But condom use often declines between year 10 and year 12. But we see here it's up in the percentage of students who sometimes or always use a condom is up in the sort of between 60 and 80%. And there's been a little bit of a decrease in that time, but it hasn't been significantly statistically significant. So in 2018, we saw that nearly 40% of young sexually active young people were using a condom always, and only 12% never. Now, if we look at unwanted sex, we know that there is more unwanted sex that's reported from women than there is from men. But in 2018, we see that 42% of year 10 girls reported unwanted sex, and 33% of year 12 girls reported unwanted sex, and smaller proportions of men. But this is important to know. It's a significant number of young people who are still at school report having been forced to have sex when they didn't want to. But one of the good things that's changed during this period of time, we see that the amount of unwanted sex as a result of excess alcohol has decreased. So for the reasons of unwanted sex, in 2002, for example, we saw about 60% of unwanted sex was to do with being too drunk at the time, but that has decreased. So the reason for unwanted sex has changed, and less of that is to do with excess alcohol. Nobody's quite sure what that's about. It may be to do with more health promotion, education around alcohol and consent and only having sex when you want it. But that does show, and quite clearly on this graph as well, that the amount of unwanted sex from secondary school students as a result of excess alcohol has decreased over time. Diversity of attraction. We see in 2018 an increased proportion of young people are saying they're attracted to the same sex, maybe as well as the opposite sex, but the same sex. And we can see that very clearly in the graph. And that's probably to do with, again, more sex ed and feeling more comfortable with being able to acknowledge that they are attracted to the same sex as well as opposite sex. So there we can see in 2018, 35% of young people in 2018 attracted to both sexes. Yeah. And it was a much smaller proportion in 1997. Yeah. 3%, but now 34%. So a significant increase in young people feeling okay to report that they are attracted to both sexes, same sex and opposite sex. Okay, so young people and sexual health. So some of the consultations and the issues that you may come up in when you're dealing with young people and sexual behaviour. So what do you need to ask about and what do you need to think about? So the things that I always think about, and as I get older, I think this more and more, that the important thing is this young person safe? Do you feel that this young person is going to leave your consultation and actually be safe and not be at risk of significant harm or is not particularly vulnerable? So that's what I try and assess overall, the safety of the young person. But the questions I ask to give me some information about that safety are how old they are and how old is their partner. I bear in mind the legal age of consent to sex, which I'll talk about in a minute. I bear in mind the requirements around mandatory reporting to child protection. I bear in mind the issues of confidentiality. I think about and I try and assess whether they're competent to consent to the medical requests that they're making. And I think about the new legislation around failure to disclose and failure to protect legislation, which I'll talk about as well. And some people look at that and think, my goodness, how do you assess all of that in a short consultation? Because I know in general practice, you're seeing a lot of patients relatively quickly. My experience has been that 90% of the time it's quite easy to make this assessment relatively quickly, but there are 10% of consultations which are really tricky and difficult and you're unsure about the young person and they do take a lot longer and you may need to get extra advice around those. And there are always people available to talk to about these young people who you find difficult because you're unsure of their safety. So how do we assess sexual risk? Well, first of all, we take a sexual history, and the basics around a sexual history is when did you last have sex? Who was it with, male or female? One partner, many partners, regular partner, casual partner? Did you use a condom? What did you do? Was it anal sex, vaginal sex, oral sex? And do you have any other partners? So that's it in a nutshell. We don't launch into that straight away. We talk about other things first of all, but that's the information we want to get out and extrapolate from the conversation that you have with the young person. But with a young person under the age of 18 and definitely under the age of 16, we would also want to get a psychosocial screening done with them. So we'd want to get a snapshot of what's going on in their lives at the moment, which would help us assess whether they're safe or not, and whether they need any extra resources and any extra input. So that involves doing what we call a HEADS assessment, and HEADS is the letters, it's a mnemonic basically. So we ask them about their home. So that might be, so who do you live with? Is that your mother and your father? Or is that a stepfather or stepmother? Are there any other people in the house? So do you have any other family members, such as uncles or aunts or grandparents who live at home? Do you have any stepsisters or stepbrothers? Are you at school? What year are you in at school? What school do you go to? Do you have friends at school? Are you happy at school? Do you have friends that you can talk to? Are there any adults at school who you feel you could confide in if there was a real difficulty? Do you feel, how do you feel you're doing at school? Is your work okay? Do you have plans of what you do when you leave school? You're not being bullied, are you? Or do you want to talk about any of that? Is there a welfare officer you can talk to? So generally discuss the factors of what's going on at school. And they're not just school or employment. If they're not at school, you need to find out where they're working, what they're doing, but what they do outside school and who they hang around with and what they actually do. Do they smoke? Do they drink? Do they use drugs? And if they do, how do they get the money to use those things? Are they having sex? Are they sexually active? And if they are, who's that with? And what are they doing? Are they having any concerns about their sexuality or their sexual behaviour? Do they want to discuss any of that with you? And have they ever had a diagnosis of poor mental health, so mental illness, suicide, ideation, self-harm? Have they ever been depressed? Have they ever seen a counsellor? Do they have anxiety? Those are the sort of issues you need. And if you ask all of these questions, you can ask it relatively quickly, make some notes and jot them down, and then at least you've got something to talk to the person about next time they come, and also somebody else sees them, they've got that information there, and it really does help you assess sort of overall holistic view of what's going on in that young person's life at the moment, because all of those things are really important when you're trying to assess whether they're safe or not. So what's the purpose of the HEADS assessment? If you were to ask me that, I would say it helps me assess their safety. It helps me build rapport. It helps me look at risk and protective factors for that young person to make some sort of balanced assessment. I also get some idea of their maturity with regards to, you know, what they're doing. Are they in year 10, but are they behaving in a very mature way? And so you're feeling that they're very mature and they have some cognitive maturity. It helps you make an accurate diagnosis. It may help you with any interventions you want to think about. You can also give some health education around that. So you can talk about STI prevention or services if they tell you they're having sex, but they're not quite sure about contraception and things like that. And also vitally important is you can make notes which help you with your assessment, but they also help you as a prompt for next time, and they might help another practitioner who actually ends up seeing that patient next. Okay, so those are things that you want to assess. I'm going to talk a little bit about some cases, and I'm going to just highlight some scenarios, and then I'm going to talk away myself and talk to you about all the issues that come up, and then we'll come back to these scenarios at the end. So you may see a 14-year-old having sex with a 17-year-old, or a 15-year-old having sex with another 15-year-old. You may see a 13-year-old who's having sex with a 15-year-old, or having sex with a 16-year-old, or having sex with a 19-year-old. And all of these may bring up certain issues, and I'm going to discuss them with you now as we go along. So this is just a fabricated case, a young girl who presents to a service saying she's 14 and she's 14 weeks pregnant and she wants an abortion, but she doesn't want any parents involved. That's not an uncommon scenario. It can be a challenging scenario for some people, but you might want to pause here and think about what you would do in that situation. So what happened with this young girl was she was assessed by a medical practitioner as being competent to consent to a medical procedure, and she was therefore referred to a provider for an abortion. But this provider refused to give her an abortion because they do not undertake second trimester terminations, that's more than 12 weeks gestation, if the young person is under 16 without parental consent. Now again, just maybe pause it and have a think about that, whether that is correct or that is not correct, not exactly best practice of what we should be doing, but have a think about how you would deal with that situation. So some of the issues raised by this case are the legal age of consent to sex, competency to consent to the medical procedure that she's requesting, confidentiality of that consultation, child protection legislation, the new failure to disclose legislation, and abortion legislation. And we're in Victoria, so I'll say, because abortion legislation is different in each state. So in Victoria, the legal age of consent to sex, under the age of 12, there is no consent that is valid. So it's illegal under the age of 12. From the age of 12 to 16, sex can be legal, providing that your partner is no more than 2 years older than you. And from the age of 16, it's legal, as long as you're not under the supervision of your partner. So it doesn't matter how old the partner is or how old you are really, if that person is your teacher, it is still illegal. You must not be under their supervision or be supervising them, otherwise that sex is illegal, even if they're 17 years old. So competency to consent was challenged in the High Court back in 1985 in the UK when Mrs. Gillick took a doctor, a health authority, and in fact the High Court, she challenged them, saying that it was her right to know if one of her daughters went on the pill. She had 10 children, I think, and one of her children went to the doctor for the pill, and the doctor gave her the pill, and she found out, and the mother said it was her right to know that her daughter under the age of 16 was getting the pill, and it was wrong for the doctor to prescribe it without involving the parents. Now, Mrs. Gillick, she was called, lost that case, and it became called the Gillick ruling and the Fraser ruling. Fraser was the judge. It's back in 1985. And the judge ruled that a doctor was okay to provide contraception for an under 16-year-old as long as that doctor discussed with the individual about that individual discussing it with their parents, ensured that the young person understood the physical and emotional consequences of sex, was convinced the young person was likely to have sex with or without contraception, was convinced the physical or mental health of the young person was likely to suffer if she was denied the pill, and was convinced that the doctor themselves was acting in the overall interests of the young person. So those are the things you need to consider if somebody under the age of 18 really in Victoria, under 16 in the UK, but really under the age of 18 in Victoria, comes in and asks for contraception without a parent involved. So as long as you're happy with those issues, then that's fine to prescribe the pill or contraception for that young person. This was then reiterated and confirmed in Australia with something called Marion's case, which again reiterated the Gillett case, but said that there were certain medical procedures, they're called special medical procedures, SMPs, whereby a parent or an individual under the age of 18 can't give consent for. You have to go to the court, family court, to get permission to get these done. And these are things like hysterectomy, gender reassignment surgery, sterilisation, things that have long-term irreversible consequences which can be delayed. They can't be done without going to the family court in order to ask whether you can get permission for a special medical procedure to occur. In 2006, the Gillett case and the Fraser ruling was challenged again by Mrs. Axon, who said that she had the right to know if her daughter under the age of 16 was having an abortion. And again, the courts, the medical agencies and Parliament all came out against that young people have the right to confidential healthcare if they're mature enough to understand the situation. And there's no automatic right for parents to be informed if it's against the wishes of the young person. And this was defended by the British Medical Association, all medical defence organisations and all the government. It was only Christian groups who felt that this further eroded the status of the family. Now, many of us who work in this area feel that the ideal thing is for the young person to talk to her family about it and to come in with a parent or a mother or a guardian, but that isn't always the situation. And if the young person doesn't want to speak to her family and you feel she is competent to consent, then it is absolutely fine to have the young person's best interests at heart, and there's no automatic right for parents to be involved. So one of the issues that we have in Australia is Medicare and the confidentiality around that. So from the age of 15, young people can get their own Medicare card. From the age of less than, there can be difficulties, let me start again, there can be difficulties with this because under the age of 14, parents can obtain detailed itemised statements of activity from Medicare without the young person's consent. And from the age of 14, the parent needs to get the young person's consent. So they need to sign something to say the parents can get that itemised statement in order to get some tax rebate. Unfortunately, even if the young person has seen a doctor, there is an itemised statement that they've been to a service. And it's very difficult for the young person to say they can't have permission to get them. So I think it's fair to say that many of us are worried that you can't completely and absolutely guarantee total confidentiality with the Medicare system for people under the age of 18. And people need to be aware that there is a possibility that it will show up that they've been to the doctor. They shouldn't have any itemised service issues in there, but it will come up probably that they've accessed and been to see a doctor. Now, in 2003, with Tony Abbott as the health minister, he tried to reverse that to say that he was wanted to raise the age from 15 to 16. But many people lobbied against that, including many adolescent medicine specialists, saying that confidentiality would be further impaired if we raised that age. And many liberals said they would cross the floor if that was brought in. So it stayed at the age of 15. So I think what we can do in practice is encourage young people to get their own Medicare card from the age of 15 and now to get their own MyGov account and help them with that confidentiality. So how do you assess if a young person is competent? Now, this is a really difficult question. There is no tick box, yes, this person's competent, this person isn't competent, but there are ways you can gain an idea as to whether that young person is competent. And as I say, in my experience, generally it's not difficult, but you can have those very difficult cases, which are definitely the minority of cases. So when you're assessing competence, you have to make sure that the young person understands that there are choices. So for example, if she comes in pregnant, she's either going to remain pregnant, give birth, or have a miscarriage, or have an abortion. So there are choices, but those choices, if she decides, for example, not to have an abortion, the choice and the consequences that she will have a baby. She needs to be willing to make a choice and have the ability to do so. So that means she's not being coerced or pushed by a parent, a sibling, or a boyfriend. She must understand the nature and the purpose of the procedure. She's going to have an abortion, for example. Understand the risks and the side effects of the procedure, the alternative to the procedures and the risks, so childbirth and the risks of childbirth. Understand the consequences of no treatment, having a baby, for example, if she's pregnant. Be free from pressure from third parties to make her own decision. And the degree of competency required for consent is proportional to the complexity of the procedure. So you may be in a situation when a young person is deemed to be competent to consent to getting the pill, but is not competent to consent to getting a termination of pregnancy, particularly if it's more than 12 weeks, for example, because that is a more complex procedure with higher risks of complications. So the degree of competency required for consent is proportional to the complexity of what is requested. So it's very important to remember. Things that help are age, level of schooling, independence, maturity, and our ability to articulate your own choices. All of those things you should gain from doing a HEADS assessment. As I say, what we need to do is a HEADS assessment, which gives us a snapshot of what's going on in that young person's life and helps us to understand where they're coming from and what's going on in family and school environments, and a sexual history with regards to whether they're pregnant, whether they might have an STI, those sort of things, and whether they're safe and having consensual sex. So there's mandatory reporting which may come into your assessment, and we know that some professionals are mandated to report to child protection if they form a belief whilst undertaking professional duties on reasonable grounds that a child under the age of 18 has suffered or is likely to suffer significant harm as a result of physical or sexual abuse and needs protection. So the important points are form a belief, reasonable grounds, significant harm. So I may form a belief, but somebody else who sees that young person may not form the belief. So it is a subjective thing, it's forming the belief. Now you may need to defend how you formed that belief, and your defence would be your notes and your HEADS assessment and other things that you've asked the young person to try and assess their safety. Now that is really about child protection, and if you feel that young person is at risk of harm, you need to report them to child protection to protect them. There's some new laws that came in about 2014 as a result of the inquiry into the handling of child abuse by religious and other non-government organisations. And some laws introduced were called failure to disclose, failure to protect offences, and the grooming offence. And these have slightly different connotations because they apply to everybody, not just health professionals. So they apply to us even when we're not working. So if you're in the community with family or friends and somebody disclosed to you about something, you may need to report that under this new legislation. And the legislation applies to all adults. So an adult is somebody 18 and over in relation to children who are under 16 years of age. And there are clear definitions of sexual offences. I've put this website in here, Youth Law, because there's a lot of really good information for young people to know what they can and can't do according to the law, and also for professionals to go and have a look at, and it divides up into different states, so it's really useful. So with regards to the age and the sexual offences, so for example, I'll give you an example. If you're at home and a friend of one of your children comes in and discloses to you that, and they're under 16, that they have been touched inappropriately by an uncle who is over 18 and they are under 16, that is something that you would need to disclose, all right? That would be somebody under the age of 16 with a partner over 18, sexual touching. All of these acts are included in it: servitude, incest, rape and sexual assault, indecent act. To somebody under the age of 16 by somebody over the age of 18. Right, now, if they're more than 16 when they disclose to you, if they're an adult and they're safe, they're not at risk of harm, and they don't want you to report, then you don't have to. So it's really you only have to when they're under the age of 16. Now, this may have implications for consultations, because if you see somebody under the age of 16 who tells you they're having consensual sex with somebody over the age of 18, you may need to report that under failure to protect, which is relatively new legislation. There are some exemptions which are here, but I think the important thing for us as health professionals is a person under the age of 16 who's having sex with somebody over the age of 18. Nowadays, that does come under this Crimes Act and the Crimes Amendment. Now, how do you report that? So it's not necessarily to child protection like mandatory reporting is, but this is usually to SOCIT, your Sexual Offences and Child Abuse Investigation Team. There's one at every big police station. They're divided up into regions. So you can just put into Google SOCIT or police station and you'll get all the reported numbers here. And often you can ring and speak to them about your concerns around failure to disclose and failure to protect, or even grooming if you feel you have some information around that. So this has really come into place since it was demonstrated in most societies that over the last couple of decades, a lot of sexual abuse, grooming and sexual offences have occurred with young people, and people have turned a blind eye. So this is to stop us turning a blind eye and to try and make sure that young people are better protected in our society in the future. So abortion legislation in 2008, the abortion law changed in Victoria, and abortion became legal if it was less than 24 weeks gestation, and after 24 weeks it was still possible with 2 signatures from 2 health professionals. Prior to 2008, we used to only be able to perform abortions under the Menhen ruling, when it was a defence for the termination if it was necessary to preserve the woman from serious danger to her life or physical or mental health, and the danger of the procedure was not out of proportion to the danger averted. That is no longer valid. We are now, since abortion reform in 2008, we have legal abortion under the gestation of 24 weeks, and after 24 weeks it's still legal, but you need 2 health professionals to sign the form. So from this case that I demonstrated to you, Olivia, we've called her, it was wrong that she was refused abortion on her age alone. All right, she should have been assessed to see if she was competent, and if she was competent, it would have been okay, medical legally, to perform that abortion, as long as she was able to consent to the procedure. Now, this organisation just had a blanket rule, which was really very defensive practice to stop them ever being accused of doing anything incorrectly, but in fact, it does impair access for young people, and it reduces their sexual and reproductive health rights. We know that access is hindered because of this. So that young person should have been seen and assessed by that service to be told whether she could have an abortion or not. Interestingly, she was actually 16. She had brought her Medicare card of her cousin, which said that she was 14, because she thought she needed a Medicare card to access the service. And in fact, it's one of the few services she didn't need a Medicare card for. So it was very difficult, and the situation was very sad, but she decided to continue with the pregnancy. The nurses at the service tried to contact her to get her to re-present to an abortion service. She decided she didn't want to, and in the end she didn't disclose her pregnancy to her family, but she gave birth to a concealed pregnancy at term, at home, in the bathroom, and her mother delivered the baby. It's very difficult to know when to go on and on pursuing these young people if they refuse to come back, but she very firmly said she no longer wanted help from this service. She was going to disconnect her phone, and that her aunt was looking after her. And I think, in all honesty, probably looking back at this case, she didn't probably want an abortion. Maybe she wasn't competent, but anyway, she had the baby in the end. And there's often not very much you can do about that. And it was discussed at great length as to when does duty of care become harassment. So I want you to look at these scenarios now. A 14-year-old having sex with a 17-year-old. Now that is technically illegal because the 14-year-old is having sex with somebody more than 2 years older than them. But as long as that 14-year-old is not at risk of significant harm, I wouldn't necessarily be reporting them. If she's not at risk of significant harm, you're not worried about mandatory protection, and you're not worried about failure to protect or failure to disclose, because this person is not an adult. So as long as they have a relationship which you feel they're both comfortable with, she says it's consensual sex, she's mature, she knows what's going on, then that, I personally wouldn't necessarily report that. However, if somebody else saw that person and they made the assessment that that young person was at risk of significant harm, they may want to report to mandatory reporting because of that. 15-year-old with a 15-year-old, that's legal sex. You're allowed to have sex from the age of 12 as long as the person isn't more than 2 years older than you. So that's okay. A 13-year-old with a 15-year-old, that's legal. So again, as long as you feel she's not at risk of harm, you're okay. There's 2 things really. There's legal sex, which is sex with somebody less than 2 years older than you, and there's then assessing whether it's harm. I don't necessarily, and this is where I do anything about the fact that it's illegal, as long as it's not in the new failure to disclose and failure to protect legislation when the partner is more than 18. So in this situation, if they have what appears to be a healthy relationship, which is consensual, this young person appears to be mature and not in a harmful situation, you may not want to report that. 13-year-old and a 16-year-old, the same thing as this really, but a 13-year-old with a 19-year-old, these days, whatever you felt about that relationship, that is probably reportable to SOCIT, because this is an adult and this is a young person under the age of 16. So that really comes under the Sexual Offences Act, the failure to report and failure to disclose and failure to protect. So this probably, in all situations, unless there was something very unique about it, you would need to report to SOCIT to fulfil your obligation to failure to protect and failure to disclose. So there seems like a lot there, but it's not, and I think you probably do all these things anyway, and a lot of it is done quite automatically. I think just it's important to take good notes so that you can defend yourself if you need to. And the important things, I think, are sexual history, menstrual history. Is she pregnant? It's always important. We've all been caught out. Heads assessment, always do a chlamydia test, always ask about contraception, thinking about LARCs being the most effective for young people. Make sure they're aware of emergency contraception, how to get hold of it, inform them about how to access services, that they're confidential, but there are limits. If they tell you that, if they disclose something to you that puts them at risk of significant harm, or that is something where you feel you need to protect them, then you may have to disclose that to either social services or SOCIT. And cervical screening, less important to young people these days because we now start at the age of 25, but it's quite good to ask them about their HPV vaccine and check that they've had Gardasil. And just think about how accessible your service is for young people, because sometimes it's very intimidating for young people to access a service, a sexual health service particularly. So really important considerations: is this young person safe? How do I assess their safety? And specific issues to be aware of: their safety, their heads assessment, competency, age of consent to sex, failure to protect and failure to disclose legislation, abortion legislation, and mandatory reporting around child protection. All really important considerations when you see somebody under the age of 18, but definitely under the age of 16 and probably under the age of 18. There's some useful links and numbers for you to contact if you need to. CARS are the Centre Against Sexual Assault. Safe Steps if you're worried about violence at home. There's a sexual assault number, a national number there. The Office of the Public Advocate is necessary if you've got somebody with a significant disability who needs consent and certain issues sorted out. And there are two websites there which are really important. They tell you about the law for young people, which are important for us because I often look at them and refer to them, and I often tell young people to go to them so they know what their rights are. Thank you.